Welcome to this pharmacology quiz on antidiabetic agents. In this video, we will cover important drugs used to manage diabetes mellitus, focusing on their mechanisms, uses, and clinical considerations. The quiz contains 10 multiple-choice, scenario-based questions. Each question includes 5 options, followed by the correct answer and a clear explanation to strengthen your understanding. There is also a companion video offering a comprehensive review of key concepts on antidiabetic agents, and you will find its link in the description. So, let's get right into it. Question 1. Mr. Anderson, a 56-year-old man with type 2 diabetes for 12 years, presents with worsening glycemic control despite adherence to metformin and sitagliptin. He has a history of hypertension and mild renal impairment, with an eGFR of 45 milliliters per minute per 1.73 square meters. His HbA1c is 9.1%, above the normal value of less than 6.5%. The physician considers adding an injectable agent. All of the following are appropriate treatment options in this patient except one. Identify the exception. Option A, exenatide. Option B, dulaglutide. Option C, liraglutide. Option D, pramlintide. Option E, saxagliptin. The correct answer is option A, exenatide. The explanation is that exenatide is not suitable in moderate renal impairment, as it is contraindicated when eGFR is less than 30 and used cautiously between 30 and 50. Dulaglutide and liraglutide are safer GLP-1 receptor agonists in such cases. Pramlintide can be used as an injectable adjunct to insulin, and saxagliptin is already being prescribed in this patient's therapy. Therefore, exenatide is the exception in this clinical setting. Question 2. Mrs. Johnson, a 43-year-old woman with uncontrolled type 2 diabetes, is prescribed pioglitazone in addition to metformin. She has a history of congestive heart failure, New York Heart Association Class II, dyslipidemia, and obesity. After 2 months, she reports leg swelling and weight gain. Which of the following adverse effects is most characteristic of pioglitazone therapy in this scenario? Option A, fluid retention. Option B, hypoglycemia. Option C, constipation. Option D, rash. Option E, hepatotoxicity. The correct answer is option A, fluid retention. The explanation is that thiazolidinediones such as pioglitazone are well known to cause fluid retention, leading to edema and weight gain, which can worsen heart failure. Hypoglycemia is not common unless combined with insulin or sulfonylureas. Constipation and rash are nonspecific and not characteristic adverse effects. Hepatotoxicity is rare and less prominent compared to the fluid retention effect seen with this drug class. Question 3. Mr. Miller, a 68-year-old man with long-standing type 2 diabetes, is taking glipizide. He was admitted after an episode of hypoglycemia following missed meals. He also has stage 3 chronic kidney disease. Which of the following sulfonylureas is least likely to cause prolonged hypoglycemia and renal impairment and may be considered safer in such patients? Option A, glyburide. Option B, glympyride. Option C, glipizide. Option D, chlorpropamide. Option E, talbutamide. The correct answer is option C, glipizide. The explanation is that glipizide is metabolized mainly in the liver and its metabolites are inactive, making it safer in patients with renal impairment. In contrast, glyburide and glympyride have active metabolites that accumulate in renal dysfunction. Chlorpropamide and talbutamide are older agents with higher risks of hypoglycemia and are rarely used today. Therefore, glipizide is the preferred sulfonylurea in patients with kidney disease. Question 4. Mr. Davis, a 60-year-old man with poorly controlled type 2 diabetes, has an HbA1c of 8.9%. His physician considers initiating a sodium glucose cotransporter 2 inhibitor, He has no prior cardiac disease but has recurrent urinary tract infections. All of the following properties of SGLT2 inhibitors are correct except one. Identify the incorrect statement. Option A, they increase urinary glucose excretion. Option B, they may cause genital mycotic infections. Option C, they reduce cardiovascular mortality in some patients. Option D, they are contraindicated in severe renal impairment. Option E, they increase insulin secretion directly. The correct answer is option E, they increase insulin secretion directly. The explanation is that SGLT2 inhibitors work by blocking renal glucose reabsorption, thereby increasing glucose excretion in the urine. This mechanism lowers blood glucose levels without directly stimulating insulin secretion. They are associated with urinary and genital infections, and have shown cardiovascular benefits in selected patients. They are also avoided in severe renal impairment, making option E the incorrect statement. Question 5. Mrs. Harris, a 29-year-old woman with gestational diabetes, is being considered for pharmacological therapy as diet control has failed. She has no past medical conditions and is otherwise healthy. Which of the following agents is the most important pharmacological option in pregnancy for managing hyperglycemia safely and effectively? Option A, insulin. Option B, glimepiride. Option C, sitagliptin. Option D, pioglitazone. Option E, dapagliflozin. The correct answer is option A, insulin. The explanation is that insulin is the drug of choice for managing hyperglycemia in pregnancy, as it does not cross the placenta and is safe for both mother and fetus. Oral agents such as sulfonylureas, DPP4 inhibitors, thiazolidinediones, and SGLT2 inhibitors lack sufficient safety data or pose risks during pregnancy. Effective glycemic control with insulin helps prevent maternal and fetal complications. Therefore, insulin remains the most reliable and recommended therapy in gestational diabetes. Question 6. Mr. Thompson, a 72-year-old man with type 2 diabetes, hypertension, and chronic heart failure, is prescribed empagliflozin. He has an HbA1c of 8.2% despite being on metformin. Which of the following additional therapeutic benefits is associated with empagliflozin, making it suitable for this patient? Option A, reduced risk of heart failure hospitalization. Option B, increased insulin sensitivity in muscle. Option C, enhanced pancreatic beta cell regeneration. Option D, stimulation of hepatic glycogen storage. Option E, direct inhibition of intestinal glucose absorption. The correct answer is option A, reduced risk of heart failure hospitalization. The explanation is that empagliflozin, an SGLT2 inhibitor, has shown strong evidence in reducing hospitalizations due to heart failure and improving cardiovascular outcomes. Its mechanism is through increased urinary glucose and sodium excretion, reducing preload and afterload. The other options, such as enhancing beta cell regeneration or directly altering hepatic glycogen, are not established effects. This makes empagliflozin particularly valuable in patients with diabetes and concurrent heart failure. Question 7. Mr. Wilson, a 64-year-old man with type 2 diabetes, is prescribed acarbose as part of his therapy. He complains of excessive flatulence and diarrhea. Which of the following best describes the mechanism of action of acarbose? Option A, inhibits renal glucose reabsorption. Option B, blocks intestinal alpha-glucosidases. Option C, stimulates GLP-1 receptor. Option D, enhances insulin secretion. Option E, activates PPAR gamma receptors. The correct answer is option B, blocks intestinal alpha-glucosidases. The explanation is that acarbose works by inhibiting intestinal alpha-glucosidase enzymes, which delays carbohydrate digestion and glucose absorption. This mechanism reduces postprandial hyperglycemia but leads to fermentation of undigested carbohydrates, causing flatulence and diarrhea. It does not act on renal glucose reabsorption or stimulate insulin release. Neither GLP-1 receptor stimulation nor PPAR gamma activation describes its mechanism. Question 8. Mrs. Martinez, a 52-year-old woman with type 2 diabetes, is on metformin monotherapy. She presents with nausea, abdominal pain, and confusion after an episode of dehydration. Laboratory findings show lactate 9 millimoles per liter, with a normal value of less than 2, and pH 7.22, below the normal range of 7.35 to 7.45. All of the following statements regarding metformin are correct except one. Identify the incorrect statement. Option A, it decreases hepatic gluconeogenesis. Option B, it increases insulin sensitivity. Option C, it promotes weight gain. Option D, it can cause lactic acidosis in renal failure. Option E, it is contraindicated in severe hepatic disease. The correct answer is option C, it promotes weight gain. The explanation is that metformin is weight neutral or often associated with modest weight loss, making this statement incorrect. It primarily decreases hepatic glucose production and improves insulin sensitivity. However, in conditions like renal or hepatic failure, the drug can predispose patients to lactic acidosis, which explains this patient's presentation. Therefore, all other listed statements are correct except the one about weight gain. Question 9. Baby Roberts, a 15-month-old male infant, presents with severe hyperglycemia and dehydration. He is diagnosed with type 1 diabetes mellitus and requires immediate pharmacologic management. Which of the following insulin preparations is most appropriate for initiating therapy in this pediatric emergency? Option A, regular insulin intravenous infusion. Option B, NPH insulin subcutaneous. Option C, insulin Blargin subcutaneous. Option D, insulin Detamir subcutaneous. Option E, insulin Lispro subcutaneous. The correct answer is option A, regular insulin intravenous infusion. The explanation is that in diabetic emergencies such as diabetic ketoacidosis or severe hyperglycemia, intravenous regular insulin is the treatment of choice. It has a predictable onset and allows rapid titration in acute care settings. Long-acting insulins like Glargin or Detamir, and short-acting subcutaneous options like Lispro, are not suitable for emergencies. NPH insulin is also not appropriate in the acute setting, making for regular insulin the correct choice. Question 10. Mr. Clark, a 49-year-old man with type 2 diabetes, is being evaluated for oral therapy. He is obese, has an HbA1c of 8.6%, and elevated liver enzymes. He has no history of heart failure or renal disease. Compare the following agents for their suitability in this patient. Which of the following is least appropriate due to its mechanism of action and adverse effect profile? Option A, metformin. Option B, liraglutide. Option C, pioglitazone. Option D, sitagliptin. Option E, empagliflozin. The correct answer is option C, pioglitazone. The explanation is that pioglitazone, a thiazolidinedione, is associated with fluid retention, weight gain, and risk of hepatotoxicity, making it unsuitable in a patient with elevated liver enzymes. Metformin remains first-line unless contraindicated, and liraglutide offers weight loss and cardiovascular benefit. Sitagliptin and empagliflozin are also safer alternatives in this scenario. Thus, pioglitazone is the least appropriate choice given his hepatic profile. Conclusion. That concludes our quiz session on the pharmacology of antidiabetic agents. I hope this review has helped reinforce your understanding of key concepts in this important topic. For deeper study, I recommend exploring standard references such as Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These resources will provide you with more comprehensive insights into drug mechanisms, clinical applications, and safety considerations. Please note that any guideline references in this video specifically follow the BNF.